All right, thank you. And I wanted to thank Cochs for first getting me involved with, I think, this audience. I think it's now been about 2 years. I came to one of the Cochs conferences here in this room. I think it was either last year or 2 years ago. But after we had passed the Affordable Care Act, but before kind of the enrollment and some of what we've seen over the last several months. And so it's been interesting to think about how much has happened in that time. And I was kind of asked to speak a little bit to kind of the mental health parity, substance use, as well as kind of managed care. And given the title of our panel, Integrating Services in Managed Care, I'll focus a little bit on kind of managed care, Medicaid, knowing that you're going to hear from a managed care Medicaid expert in a minute, but I'll take it on a little bit of a national scale. So some things that are interesting about what we've known from the last, I wasn't here this morning, so I know we covered some of the issues around the Affordable Care Act, but the enrollment that's kind of happened and the success that the president announced in the Rose Garden just a couple of days ago is only a piece of this, because not only are we expected to kind of figure out what didn't go very well and how to make it better, but we are projected by 2020 to have enrollment in Medicaid actually start to dwarf the number of persons enrolled in Medicare. So when you think about the kind of underpinnings of Medicaid, and especially for justice-involved populations, and the majority of those persons enrolled in Medicaid plans, there is a huge opportunity, yet at the same time, because of the fragmented nature around how Medicaid is delivered, in the sense that we've got this federal-state partnership. So, you know, unlike Medicare, where you have a Medicare card for Part A and Part B, and you kind of know what that means across the country, or you think you should know what that means, Medicaid plans don't all look the same, and certainly managed care Medicaid plans don't all look the same. And the overarching, I'm going to kind of speak, since I know there's a really heterogeneous audience here, something that those of us who study kind of the financing of health care have been looking closely at, is that there's been an assumption by many governors and many state officials that managed care Medicaid is ultimately cheapest, and you see states moving kind of 100% wholesale into managed care Medicaid plans. The evidence has been to this date mixed in terms of whether, you know, managed care Medicaid means that you can achieve even that cost part of the triple aim, and even more mixed when you try to look at the three parts of the triple aim and thinking about that. So that's just what's plaguing kind of the healthcare side as we're trying to move and add millions to a program. Now let's think about justice-involved populations. People have already spoken about the silos. There are so many reasons and problems with just getting the enrollment right, and I don't want to delve into that. But then let's hypothesize that all of you are in environments where you've at least figured out how to deal with enrollment, whether it's into the marketplace, which are not as many of the justice-involved persons, but are some, and then the majority, which are in Medicaid, had not previously been covered, have been new to the system, all the things that Dr. Boutwell talked about. And then we start to think about how complex then managed care is, and how then someone who might be enrolled and feel like you've got some tangible success when they come out of the system into the community settings and then try to seek care. And these are, all of you know that as a doctor, patients with higher levels of chronic disease, higher levels of substance use, mental health disorders. These are the very people that need probably the higher intensity of services, only to then be told, well, your managed care plan won't allow for your doctor to write for this adherence program, or you need to do this, and you need to wait, and prior authorizations. And you can only imagine how defeating that might feel to someone who has just felt a little bit of a victory in finding some pathway to enrollment in health insurance. Combined with the churn and transitions, I don't want to talk about that, but I do want to, given this audience and how all of us are probably going to go home and think about kind of all the other things we have to do, I would like, for those of you who are in kind of, you know, working more closely with justice-involved populations, kind of in facilities, in transitions, trying to understand how you can have a better linkage to the managed care plans, to the Medicaid directors in your states. I actually called two friends of mine, prepping for this panel, I called two friends of mine who run the Medicaid plans, Medicaid programs in Colorado and Oregon. Two really progressive states who have expanded their Medicaid programs, who have tried to do active outreach. Both of them have said, we have just been so slammed by what we have to do kind of for our own state's requirements that we've never done a meaningful linkage in terms of what we have to do in expansion and what that means for people in correctional facilities. And then they further went to say, well, we've talked to some of the federally qualified health centers who might be delivering care and have navigators, and we're trying to do better communication. But they were both very honest, and then Dr. Boutwell and I had a conversation pursuant to that, where if a Medicaid director was asked to identify the population that had some of the most critical needs, might be utilizing the hospital as their primary care source, because that's what they've always done, most Medicaid programs don't even really have the data to understand how they can deal with that issue at this present time. So it's not just the data, it's not just the cost, it's not just that the website didn't work and it's all confusing for all of America. It's that we're really trying to take these highly kind of siloed and complex systems, the correctional facilities, transitions in care, community-based settings, all these systems, and we're trying to kind of blend them together in ways that are not very natural. And so for each of us in the room, I would say, what's your opportunity to kind of go out of your comfort zone and think from a policy perspective, how can I play a more active role in working with either our state or the local health facility or the integrated health system that's in the neighborhoods that that your population might be in, and what can we do to make meaningful linkages? And I think the great thing about the Affordable Care Act and kind of integrating services is that there are dollars for this, but you have to find them, and you have to be creative about it, and I think that's where it does take a little bit of a lift. I've also seen New York State had put in like a $12 billion waiver for Medicaid. Certainly California kind of set the path with a very large billions of Medicaid dollar waiver. Texas followed. Numbers of states have been trying to work with the federal government to say, give us extra money, but in return, we're going to show you that we can deal with the triple aim, and we can do it better by you giving us this money and letting us do what works locally. Now, unfortunately, the bad news is that it's just not very intuitive. If you're not really into kind of integrated health settings, sometimes it can feel like those resources or the people who are making those decisions are much more removed from your day-to-day interactions. But I think when we kind of looked at programs for our article around coordination and some of the amazing work that's gone on bootstrapped resources coming from communities where people had high rates of HIV, high rates of chronic diseases, mental health, it's amazing what's already been done on so little, and now there's actually an opportunity. I'm not saying there's an infusion of money, but there is an opportunity to revisit the dialogue to kind of change the way managed care, Medicaid, might apply in your setting. So those are just a couple of points. Mental health, I think I'm personally still trying to kind of figure out, every state is kind of dealing with mental health parity and how that impacts behavioral health carve-outs and where that comes into kind of MCOs, PIHPs, all these acronyms around managed care. And so it's not something that you can say nationally, here's exactly what's happening. However, there is still kind of this real sincere desire. I mean, part of it is that it's a law. We have to have mental health parity with kind of physical services and physical health treatments and benefits. But part of it is also how these programs are administered, and given justice-involved populations' needs in the area of mental health and substance use, it probably makes a lot more sense to pay attention to some of the managed care Medicaid's plans on how they have kind of rules and what they do after, after a 24-hour admission, how they deal with patients that are now hospitalized. There are so many aspects that I think need to be a little bit more on your radar than they might have been before. The good news is that there is law that kind of necessitates that equity. The bad news is that that can be left to interpretation in certain ways. So I had a couple of, I wanted to kind of think about some practical tips, because I do encourage all of you, those of you on the health side, those of you who are more on the correctional side, and those in between, to actually conduct a dialogue with each other. I actually think that asking for lists of covered mental health services, things that are contractually kind of obligated, things that you can get that aren't something that are out of this kind of world for you to consider when thinking about managed care, Medicaid settings. Plans definitions of medical necessity. It's very interesting how kind of the interpretations and association of what's medically necessary can be construed in different settings, and how much of an impact that can have on what you might tell a client is available to them now that they're newly enrolled in Medicaid, for example. And then just, there's a lot of, I think, attention on the health side. Amy and I spent a lot of time talking about quality of health care, access to health care. I think if I were to remove myself from our healthcare bubble, I would wonder, what does that really mean? And especially in Medicaid, we don't have kind of universal quality we don't have these 100 of measures that every single Medicaid plan ends up kind of being accountable for. Actually, no health plan really has that, but it's really even harder sometimes in Medicaid, but especially with respect to substance use and mental health disorders, the quality measures are still being developed, still being kind of organized. And so I'm also putting in a plea for you to consider what a framework for quality would mean in your community. I do believe that some of these things are going to have to be done locally and not necessarily kind of handed down from a national organization and be told this is what this means. So when I think about integrating services in managed care, I kind of shift and pivot a little more towards a advocacy-oriented policy focus. The bad part of the Affordable Care Act was that because the Medicaid program is this federal-state partnership, you don't see a lot of heavy-handed language about things that Medicaid programs must do with respect to certain populations. So I would say that that can be a great opportunity if you're savvy and know how to have a communication channel. Those of you who are in states where you did not expand Medicaid and you have some real problems around a kind of, I've been describing a donut hole effect that can certainly affect a number of folks in justice-involved populations, you're going to also play a very important role in helping people understand what that means. They may have not even heard that they could have had a chance to enroll in something, and then because the state didn't expand Medicaid, they may or may not realize that they also could have an opportunity to enroll in an exchange plan. And then people have all been paying attention to the news that the enrollment finished on March 31st. There are actually a lot of kind of exceptions so that people can kind of get added in. You can even call to see. Remember, Medicaid goes all year, so Medicaid is one thing. But with respect to the exchanges in the marketplace, as people change conditions in their life, divorce and changes in employment, that's actually another opportunity to enroll. So if I had to say something about integrating services, I would say first and foremost is kind of an information awareness effort on each of our parts, and then second is really meaningfully engaging with the very people who kind of construct this triple aim and having an explicit conversation about the special needs of a population as well as the great opportunity. I think people all assume, I'll just say there's such a stigma attached to this population, and people assume it's just take, and need. And what's really been amazing is I've learned so much about some of the programs that have encompassed and some of the things that are in place now and how much it allows for justice-involved persons to be meaningful contributors and giving into society in a way that we take for granted because we get health care and I can be healthy and be productive, but most people don't have a chance. So I'll stop there and I can go into lovely details about MCOs and other boring statistics if you want to during Q&A. Otherwise, handing it over to Jonathan.